75-year-old patient found down at home on no downtime. He's a diabetic. That's what we got, and we have no access.
Let's get him over on the stretcher.
One.
Hold on. Okay.
One, two, three.
All right. Resume compressions, please. All right, guys. So let's try to get IV access.
Yep, I'm going with central line.
Excellent. We got
I
central
have
line
an
by
18
Zach.
in the right AC.
And let's get a tube as quick as we can. We can get that epi through with the 18, but I would really like some central.
She's really interior.
Can you work compressions?
I'm ready for the epi.
Please administer.
All right, I
Epi
see
is given.
cords.
You got cords?
Yep.
Are you getting the tube?
Okay, tubes in.
All right, back on the chest, please.
I haven't had a lot here.
Thank you.
Can you hold compressions 1 second?
What do you got? We need that central line.
Yeah, I got a flash.
We're
Okay,
ready
back
for a
on the
pulse
chest. Back on the chest. Let's get this line in.
We're ready for a pulse check when you are.
1 sec.
Wire won't thread. Hold on, just pause 1 second. Yeah, that's better.
Okay, back on the chest. Alright, we got central access.
Yep.
We have given 1 round of epi, we got a tube in, and you're saying we're coming up on a pulse check?
We're ready for a pulse check.
Alright, let's have a pause, check pulse, check the rhythm.
We have defib on this monitor.
Yeah.
Okay, let me get the ultrasound.
I don't have it.
Hold on.
I don't have a
It's-
pulse.
It's on the vascular, let me switch over. Switching. Okay,
Defib on the monitor, so.
yeah, and I'm seeing fine beat fib with the ultrasound too. Alright,
Yeah. What is
Yeah.
it again?
you want, I think that's fibulatory,
Okay,
right?
yeah, looks like
Definitely.
defib.
So let's charge for shock, back down. Wait,
Charge.
no, we're charging, everybody clear, we're
Everybody
charging up.
clear. Charging.
Charged,
Administer.
shock, okay, back on the chest please.
Blood off here.
Okay, so there was a mock code, and obviously there's a little bit of dramatization in there, but if you really think about it or true to yourself, some of those pauses, time spent off the chest, aren't that far off from what you see in the resus bay sometimes. So we just wanted to highlight that for this lecture called On the Chest, Resus Interruptions, Where They Are, and What We Can Do. So a lot of the things that we do in our cardiac arrest patients are necessary. They help the patient do better, help them have a better chance of survival. But some things are simply distractions and have no effect on patient outcome. And we're going to try and separate those two things out today.
All right, so first, before we talk about anything further, we need to understand the hemodynamics of cardiopulmonary resuscitation, CPR. And here's a great graph to help you kind of visualize what's going on. So Berg, this guy in Resus 2001, basically was looking at the blood pressures that were attained during CPR sessions. And what did they see? They found that with time, there's actually a buildup of systolic blood pressure during the CPR process. You don't just suddenly start CPR and get a perfusing pressure. You have to put in a little bit of work, a little bit of time to gain a systolic pressure and increase your coronary perfusion pressure. Visualized another way, you'll see that with some time you get to this point, and you do eventually hit a plateau. It doesn't just keep going up and up and up and up, but you hit a plateau, and in this example here it is 80 over 60 roughly. That's your, with best possible compressions, that's the systolic blood pressure you're able to attain. And that's the best you can do. That's hopefully giving your coronaries a little bit of blood, a little bit of oxygen, and trying to get that heart back. And what you find is when you stop the compression, you quickly plummet down to nearly nothing. And when you get back on the chest, you got to gain that back. You don't go right back up to 80 over 60. You got to work for it again. So this model is incredibly important for the discussion we're going to have today. All right, so the question comes, who cares? You say, so I stop my compressions for long periods of time, all the time. Big whoop. Want to fight about it? And yeah, kind of I do a little bit, because it has an effect on your patients and their ability to come out with ROSC and come out with a good neuro outcome. So it's worth knowing. It's worth fighting about. So basically what you're going to see is through the course of this, we're going to be talking about the death by pause. Pausing compressions increases mortality. That's what we're seeing. And I put this little reference here on the bottom with Meany, and it's the consensus statement by the AHA. I don't specifically cite it, but it has a great deal of references in it, and it was a resource for me to gain the primary literature, so I had to include it as well. Alright, so I heard this early on in my training, that for every 10-second pause in compressions, mortality increases by 5%. And that stuck with me. I was kind of like, holy jeezum, that's actually a pretty significant increase in mortality for not a lot of time. And as I looked at the data for this talk, I found that maybe this is more of an ED proverb. I didn't find a direct cite for this, a direct reference for it, but the theory still stands that for every pause of X seconds, mortality does increase by Y. And what you'll find as we go through the data, that there's a different unit of measure that they're using now, or that is being used, called the CCF, or chest compression fraction. And what this means basically is they're looking at what percent of the total resuscitation time is spent with someone actually on the chest doing good CPR. So something to remember, the CCF. Alright, so let's look at some of the data. So this guy, Valancourt, I really wanted his name to be Vanilla Court. I thought it was, but it's not, and I can't call him that, so it's not that. In Resus 2011, what they did was they looked at the percentage or the compression fraction done by EMS in pre-hospital patients and broke them down into quartiles and looked at ROSC. So they had about 2,100 patients. And again, this is pre-hospital. This is EMS stuff. They broke down these 2,100 resusces into you spent 0 to 40% of the time on chest, you spent 41 to 60% of the time on chest, etc., etc. And they looked at their ROSC. And you find a pretty substantial increase with time. You know, you put, or with percent spent on the chest. You spend 80 to 100% of your time on the chest, you have a much better chance of getting ROSC for your patients than you do if you spend 0 to 40% of your time. And this study was in non-VFib patients. This is your PEA and asystole patients. Still pretty significant change. All right, another study. This is Edelson et al., Resus as well, 2006. Resus has all of the best articles on this stuff you'll find with, as we go over things, it's all pretty much Resus. They're the main game in cardiac arrest data. So Edison et al., they looked at only 60 patients. They had only 60 patients in their study. They looked at in-hospital arrests, and they looked at the depth of the compression and the length of the pre-shock pause on the success or failure of that shock in getting someone out of VFib BTAC, and what they see. So they were finding that with pauses less than 10 seconds, you had a statistically significant, much better chance of having shock success. If you sit there, twiddle your thumbs, mess around, joke about, spend more than 30 seconds between your the end of your compressions and the delivery of the shock, you're plummeting down to a much, much lower shock success rate. So getting your time from pause for pulse check, pause for rhythm check, and shock, getting that down to less than 10 seconds had a huge impact on shock success rates. Alright, so then you're asking yourself, what's the point? Well, wake me up when you get to the point, Jay. Just, what are you talking about? And what we're finding is there's a lot of good evidence out there that pauses kill. And that's what we're talking about today. We want to decrease these pauses because we don't want to kill people. So then the question becomes, where do we lose time? Where do we pause? Where are we killing our arrest patients? Where are we killing these dead people? And there's a few specific ones. And we're going to be talking, I should pause here to say, we're talking some things that are more theory, some things that are evidence-based and have been studied, but it's a discussion of where we think we may be able to make up for time, where we may be able to decrease our time off the chest. So the EMS transfer, right? This is a time, as you saw in the video, where you can spend a substantial number of time off the chest. Our poor diabetic old man who was getting horrific CPR by the EMS provider who was barely making a dent in the chest, from the time that they stopped to the time that the patient was transferred over, we all had sheets, the railing was down, we counted 1, 2, 3 and moved him over. That was a pretty substantial amount of time, and it's time that can be shaved down. I don't have the randomized trials, as I was saying, to support this, but this is an idea where we can be more efficient and increase our time on the chest. All right, where's another place where we can shave some seconds or where we often lose time? And here's the ET tube of death. So if you listen to Scott Weingart or any of the other SMAC people, you'll often hear them talk about the laryngoscope as a murder weapon. And while they may not speak specifically about its use in cardiac arrest as a murder weapon, the idea still stands. The ET tube can definitely cause times where you're off the chest looking for cords, and of what benefit? So here's one study that looked at this a little bit. 2010 in Singapore, they were looking at pre-hospital intubations, and they actually were able to look at both ROSC and neural outcome at 1 month, which is great. And what did they see? So they broke their data down by relative risk, and if you can remember, a less than 1 relative risk is a negative association, if you will, with the outcome. So by placing an advanced airway in your out-of-hospital cardiac arrest patients, you decrease your chance of ROSC pretty significantly here. This doesn't correlate to exactly half, but your chance of having a good neural outcome at 1 month was significantly decreased if they took the time to put an ET tube. And this is probably from pauses to get the tube through the cords. We can't say that definitively. This is a little bit of a correlation, not causation, but that's a pretty impressive decrease by getting that tube of death in. A little bit more about the ET tube of death. So here's a study by McMillan, also in Resus 2014. They were looking at advanced airways in out-of-hospital cardiac arrests, and this was looking at the CARES registry of patients. And what they found, actually, which is just food for thought, is that by placing an ET tube or even a supraglottic airway, the patients that had no advanced airway had higher odds ratios for ROSC, survival to the hospital admission, and neurologically intact hospital survival. So the patients that they simply bagged through the code had better ROSC and better patient-centered outcomes. Very interesting, definitely food for thought. All right, so where else do we lose time with our access? Trying to get that central line in, right? Trying to get this bad boy in the groin or in the neck, if you're doing it there, or even in the subclavian. We will pause, as you saw in our video, people will pause for flash as you try to let your intern get the tube in, or get the line in, pause for that flash, and they paused again because they couldn't thread the wire. This doesn't happen every time, but it certainly does on occasion get these hands off the chest. This central line, as far as we know, doesn't bring your patient back, but getting these hands onto the chest, doing good quality CPR, does. So maybe it's time to think about a different alternative, something quick and easy that can fire the meds in, meds that we don't even know if they work, to be honest. Maybe it's time for something quicker. All right, where else do we lose time? The views, the ultrasound, the emergency medicine physician's best friend, the ultrasound machine, can do great things for you in a code, finding that pericardial effusion, but it also can be a double-edged sword, right? This video, we saw ourselves looking for quite some time, trying to find what we wanted to see, trying to get the machine to work. So where do you lose time with the ultrasound machine? First and foremost, I've seen it, many of us probably have, machine fire up. So it's okay, it's time for a pulse check. Pause compressions. Oh, the ultrasound's not on. Let's hit that on button, fire it up. A few seconds for that. Okay, we're good to go. Oh, wait a second. It's on the vascular probe, as it was in our video. Give me a second for it to transition over to the curvilinear or the cardiac probe. Another few seconds lost. And then there's the view critique. We're all perfectionists. We all want that excellent view of whatever we're looking for. And if you have an attending looking over your shoulder, that time may even lengthen further. Just critiquing your views of that. Is that fine VFib? I don't know. Some time goes by as you debate and scratch your chin trying to figure out what's going on. And then finally, you put a bunch of jelly right on the left chest. The compressor has to go over that to the sternum, slipping all over. You have to clean that off for them, and there's a little bit of time lost there.
So just a thought here, something that actually came out of SMAC when I was there and listening to Sono Wars was, why don't we start in the apical 4 chamber view, right? Compressions are going on here, right? Mid-sternum, that's where we're doing compressions. You can get your ultrasound machine on, for sure. You can get the right probe selected, and you can get it in place out of the way of your CPR provider and try and get that apical 4 chamber view, which when you get it, should give you most of the things you want to see. Is there a pericardial effusion? Is the right ventricle all blown up? What's the squeeze? Granted, there's some difficulties with that. You don't always get a good apical 4 chamber view, especially in the older patients or the patients with large breasts. You may not be able to get the view you want, and you have to slide over. But while they're doing compressions, you can see whether or not you have a good apical 4. It takes a moment after compression pause to check there and switch over to the top of the chest quickly. And you know your probe is on, you know your machine is fired up, and you're saving yourself some time there.
All right, where else do we lose time? So in the charge up, getting your AED ready to fire. That's one point where we can lose time, right? And this is a little bit of a swing back to our Edelson paper in Resus 2006. Here's a figure from it that just shows if you're ready, here's 5-second interval, right? This is a 5-second time slot. If you're ready, have your AED pads on, your AED charged, and then you call for your pause, you do your rhythm check and pulse check and see something you can shock. That takes 8 seconds, maybe less, maybe 4 seconds. And you hit that button and you can fire a shock off. But if you're not ready, you have to get the pads hooked in, you maybe have to get the charge up. That longer delay is going to affect the patient outcome, and it's going to decrease your shock success rate. So another time where we can maybe save a few seconds to shave them off by having the AED ready and charged up before we even call for a pulse or rhythm check. Okay, so those are a few examples of times where we can improve our time off the chest, where we can increase our chest compression fraction, and maybe help our patients gain ROSC, maybe increase their chance of having a good neuro outcome 1 month down the line. I'm not saying that this stuff is a miracle cure. I'm not saying it's amazing, it's going to work in minutes guaranteed, but it may help. And in a disease process that already has a pretty poor prognosis, you're fighting an uphill battle. Some of these things are worth taking into consideration and maybe putting into practice in the future. Thanks for listening.